Our panelists and we're getting a really fun discussion. So that's the course of the day for the morning, and I'm turning it over to Vanessa, and I'll sit down.
All right. Well, good morning, everybody. This is Xiaoyi Huang, and she's from the National Association of Public Hospitals and Health Systems. And actually, I worked there from 1992 to 1995, and John and I found out that we were affiliated, might have been in the same conferences in those 90s, in those days. But you know, what she's going to be presenting on is the impact of health reform and how it may impact us locally. And she already stated to me that she would like to have some kind of a dialogue, you know, make sure that we are asking questions and make this interactive while she's presenting. But the members of the National Association of Public Hospitals and Health Systems, they serve the poor and low-income populations that we serve too. And the poor go to these health systems, and they have to be very conscientious about you know, how these folks can be connected to other certain resources in the community. And actually, that's where I learned about what services are needed for the poor by working in that organization and understanding the folks that are coming through the emergency rooms and why it was so important to have some kind of systems of care out in the community. And so actually, that was my that's where I got my aha moment about why it's important for everybody to be working together, and that's the work we do. So anyway, come on up, and thank you so much for coming to our conference. Welcome. Yes.
I can look for you. Oh, yeah. Oh, it doesn't have room.
Well, thank you, Vanessa. And as she mentioned, I do very much want you to just interrupt me, ask me questions whenever. I'm a little less familiar with this particular audience. I tend to do this presentation with the hospital and physicians in mind. So I try to tailor it, but wherever it doesn't make sense, definitely just jump in and ask some questions. So I just want to tell you a little bit about NAPH. We are, this is our 30th anniversary. Actually, we've been in existence about 30 years, right when Medicaid disproportionate share hospital payments was created. And that's a really important source of funding for our members to be able to take care of the Medicaid and uninsured patients. We represent, as Vanessa mentioned, some of the larger metropolitan area safety net hospitals and health systems around the country, and they all pretty much share one mission, and that is to provide care for everybody, regardless of ability to pay. And the next slide lists just some of our accomplishments over the years. The one thing is actually the creation of the DISH payments that makes it possible for some of our health systems to take care of these patients. And during health reform, we were an integral voice for the safety net in making sure that coverage expansion stayed and throughout the health reform debate. So really telling you a little bit more about our members, I think this is the slide that captures everything. We are about 2% of the acute care hospitals nationwide, but we provide 20% of the hospital uncompensated care nationwide. So that's all the charity care from the uninsured patients, as well as actually no, this is just the charity care piece. I have a slide later on that talks about the Medicaid and uninsured, Medicaid and Medicare. So in the community, the next slide has in the communities that our members are in, you can see what kind of impact they make. They can pretty much provide about 1/3 of all outpatient visits, and they treat 1 in 4 emergency room patients, and deliver 1 in 5 babies, and they operate about 40% of all level 1 trauma centers and 60% of the burn care beds, and they train 1/4 of the tomorrow's U.S. physicians and allied health professionals. And in the top, and this graph just reinforces what I just said. This is only representing the 10 largest U.S. cities where our members are in terms of the same thing I mentioned: emergency visits, Medicaid discharges, outpatient visits, trauma center, and burn care beds. And unlike a typical community hospital, our members have large ambulatory care networks, and it really gets to, it's a result of the patient population that they serve. And when you really look at us with the community health centers, if you just group the outpatient visits provided by all of our hospitals and every single community health center in the country, we do about almost 40% of all outpatient visits. And the 1,000-something community health centers do the other 62%. And And the next slide gets to what I was talking about earlier. You can see it may be a little difficult, but the bottom, the darkest color, is uninsured. The next level up is Medicaid, and the following one is Medicare. So you can see that about 70 to 75% of the patients that come in to use our member services are uninsured, Medicaid, and Medicare. And we know from a further analysis that most of our Medicare patients are what are known as dual eligible, so they're both low income and elderly and or disabled. And the next slide also drives home the point, the importance of some of the safety net financing for our members. You can tell without any of Medicaid DISH or the other supplemental payments, we would end up in a very negative margin. With those, we are still less than community hospitals nationwide, but it's enough to sort of sustain us. With that, I will, and before I get into sort of the health reform stuff, I think we all hear in the news about different budget proposals and a deficit reduction plan that kind of threatens to change the Medicaid and Medicare programs from what we know today. And it's a little difficult to talk about health reform with that going on in the background, because health reform predicates on a Medicaid expansion. So what happens, in the current budget proposals if Medicaid doesn't exist as it currently is, or it's severely curtailed? So it's one thing to keep in mind, and we know there are plans out there by the Republicans in the House to kind of turn Medicaid into a block grant program. And it's important to kind of think about what does it mean when a program that is currently essentially anybody who qualifies is guaranteed care. There are little access issues, but to turn it where the federal government caps its investment and really relies on the state and local communities to pick up the tab. And we know that in these budgetary times that it's really difficult to generate the local source of funding to be able to continue to support this population. So it's kind of important to keep that in mind. And we know the president is very supportive of health reform with all the coverage expansions. However, he's also getting a lot of pressures to really deal with the deficit. And we know that he, back in November, his appointed Deficit Reduction Commission, bipartisan commission, came out with a recommendation on how things you can do to Medicaid and Medicare, along with everything else, to help reduce the deficit. And there are some things in there that are a little worrisome, particularly involving how state and local communities can raise the funds to help draw down some of the federal dollars to care for this population. And we know that he recently announced this past Wednesday in his deficit reduction plan that he's flatly rejecting a Medicaid block grant program, which is good to know, but we have a block grant proposal on the one hand and no block grant, so we'll end up somewhere in the middle, which will likely look different still from where Medicaid exists today. That being said, he's also, he has to eke out some savings from the Medicaid program, and there's not a lot of detail other than the fact that he expects to save about $400 billion over the next 12 years out of Medicaid and Medicare, and about at least $100 billion of that is coming out of the Medicaid program. And there's some talk about a single match rate, so I don't know how familiar you are with the financing, but it's a Medicaid is a state-federal partnership, and it's based on there's this FMAP, the Federal Medicaid Assistance Percentage. I've seen many of you nodding. So right now, that FMAP is set based on certain indicators. So the poor state that you are, you get a higher match, so the federal government kicks in more. Well, there's some talk about moving that into a single match rate. So again, it's not a block grant, but it's another change to the Medicaid program that will potentially affect how local and state communities are able to continue to generate the sources to fund the care for this population. So with that kind of depressing background on what's going on today, we can put on our blinders a little and think back about a year when health reform was passed, and really talk about where things were going at that point and everything that is currently in law through the Affordable Care Act that present some opportunities. So I'm going to focus a lot on the coverage expansion pieces of the Affordable Care Act, and think, not just from the provider perspective, but certainly from the community perspective. When patients have coverage, it's a better thing. And then following that discussion, I'll sort of move on a little bit towards some of the opportunities in the health reform law that I've, tagged as potential opportunities that local communities can think about in terms of taking advantage of or partnering with other organizations to take advantage of some of the opportunities in there. before I sort of just get into that, the health reform law does sort of broad base. What it tries to do is really change the healthcare delivery system in the U.S. And it does this in a couple of different ways. There's the coverage expansion piece, which we'll talk about, and then there's the incentivizing providers and communities to move towards this more seamless, integrated care for the patients, away from the current fragmented system. And to do that, there's a lot of investments at the primary care level, at the preventive care level, and so some of what I'm going to talk about later on will focus on that piece, and less so on the changes to the provider payments that help incentivize that area. But you should know that there's those carrot and sticks out there as well for the providers. So I would say that the major accomplishment of health reform, and something that NAPH very much supported, is coverage and access expansion. And it does this through a couple of things. One is expanding the current Medicaid program. The second thing is creating these state-based exchanges, which essentially is a virtual marketplace where if you don't have health insurance through your employer, you don't qualify for Medicaid or Medicare, this is the place for you to go. Unlike, I guess, instead of the current individual market that exists prior to health reform, this is the place that you can go to find affordable coverage. And at the end of the day, what CBO has estimated by 2019 is that 32 million Americans will be covered as a result of these coverage expansions. And that we know that represents about 92% of the population. And I'm using the second figure there because that includes undocumented immigrants. And I know that many of you are aware, and as are our members, and this is a population that won't get coverage, but they will continue to have a need, and they show up somewhere, and they need services. So it's something to keep in mind that, at the end of the day, even when everything is implemented perfectly according to plan, you'll still have 23 million uninsured individuals left in the U.S. Now, the current number is about 50 million, so it's a drastic reduction, but it's a sizable number. And about 8 million of those people are undocumented immigrants that I talked about earlier. And specifically, according to the Congressional Budget Office, who does all of these estimates, long-term planning to tell you what's going to happen 10 years from now, they expect, so I mentioned that 32 million Americans who's going to gain coverage. 16 of them are going to gain coverage through Medicaid. 24 million net will gain coverage through the exchanges via subsidies, and 5 million additional through employers. And you see that in your employer coverage, the 3 million figure there is these people, instead of buying it through their, or instead of having health insurance being offered to them through their job, they're going to buy it on the exchange. So the employer market